So Dr. Shuddho Satvaya Chatterjee is going to present the session. He is senior consultant physician and rheumatologist at Apollo Multi-Speciality Hospital, Kolkata, and Department of Internal Medicine and Geriatric Medicine. He has national and international publications. He is COVID inspector and guide of West Bengal Health Ministry. So I am giving this overing the session to Dr. Chatterjee. So over to Dr. Chatterjee, please.
Thank you, sir. Thank you for your kind introduction. A very good morning to everyone. I am fortunate because I am at Venu with my colleagues of Geriatric Society of India, and with due respect to my senior colleagues and my friends, let's start. Today I am seeing that our department or the rheumatology is sandwiched between two things. One is antibiotic, another is infection, that is chronic diarrhea and tuberculosis, which will come later. So actually we are making the patient immunocompromised, and the antibiotics and infections are coming, because I will say at least a few medicines which are not indicated because of latent tuberculosis. At the same time, some of my medications can lead to tuberculosis in elderly. So I am a bit tensed, though Dr. Dharmanand has made my topic a bit easier. Thanks to my colleague and friend and the organizer, Dr. Krishnanjan Chakraborty, for giving me the topic. When I am thinking of this topic, armaments of rheumatological treatment. So let's come to some questions, and let's begin with questions and answers in this way. So my introduction is like that. What are armaments? What are the armaments in rheumatology? Non-medicinal armaments as well as the medical armaments. And during the medical armaments, we will consider about the medications and non-medications as well, the older one, time-tested one, and the newer ones. So let's begin. Can we take that medicine or medicinal things as an armament? Here you are seeing the armaments. The dictionary meaning of armaments is a military force equipped for war. Is the word appropriate here at all? Is the medical science similar to a battlefield? Yes, last 2 years we are seeing that actually it is. The total COVID case rate is 4.28 crores just 2 days back, with a death of 5.11 lakh, that is half of million. If you compare with the total number of deaths in World War I and II, that is 20 million and 56 million over a period of 5 to 7 years, which is quite considerable. And at the same time, you can see the healthcare workers died approximately 1.8 lakh, almost 2 lakh healthcare worker dies in these 2 years. So as we are seeing in the warfare, the army men as well as civilians are dying, or rather killed. Here we are checking similar things. Both the war armies like doctors and paramedics and the medical staffs, as well as the audience or the civilians, are dying because of the COVID or any other diseases. Say in rheumatology disease, though it is a chronic disease, it's not killed like a COVID at a time in a pandemic way, but it can causes the comorbidities that can lead to the COVID to work over it in such a way that it can cause more comorbidity and mortalities. So it's a war, no doubt about that. So basically we are in war field and we need armaments. So let's see what are the armaments in our department. Drugs, diet, some specific exercises, some therapies like physical therapy, occupational therapy, hot and cold therapy, some accessories like sprints, braces, assistive devices to support weak joints, relaxation therapy, and surgery in particular cases. Because we are dealing not only with rheumatology now, we are dealing with the old age people as well today. So we need supports. We make our older people, our older relatives, much more active, much more productive, so that they can do their normal needs and they can be productive as well. So let's start one by one. Starts with drugs. Is the most and almost entire part of my topic, because the rest of the thing a bit speciality and needs a much more time to discuss. So we can start with the history before 20th century. Charaka in our country was the pioneer of rheumatoid arthritis. Vishkantha was meaning a painful joint. He wrote in Samhita. Hippocrates is the counterpart in the European area. At that time, gout was given much more priority because they could not differentiate between the gout with the other rheumatological illness at that time. Galen described tophi, a crystallized monosodium urate deposit present in gout. Greek physician Soranus in the 2nd century AD described differences between the gout and the other type of arthritis. This is the first time it came that differences between acute and chronic gout. Similarly, Guillaume de Baillieu, which was the French physician who was the first, told the term rheumatism, and he was the father of rheumatology. You can see these famous names. Sydenham, you know the name in Sydenham, Korea. He first time described rheumatic fever-like things. Similarly, William Harbenden is also, we know Harbenden notes, he make a difference between a gout and osteoarthritic notes. Garrod, George F., these are the 1859, 1857 or 1850 onwards to 19th century. Here, they tried to differentiate between the gout with other gout-like arthritis, like rheumatic fever, rheumatoid arthritis. Now come Benjamin Christian, who found colchicine as an alkaloid derivative and the treatment of gout in 16th century. Phoenix Hoffman first time discovered aspirin from acetyl salicylic acid. So now comes the 20th century, the century of revolution in medical science. So in 1948, just 1 year after our independence, it's a magic year. It's a landmark year for rheumatology. The RA factor was diagnosed, Elisel phenomena was diagnosed, and most important drug at that time, that is steroid, was diagnosed. So I made a period between 1948 to 2000 where we are getting more drugs on proper rheumatology, not gout, not osteoarthritis. So here you can see the milestone in rheumatology came after discovery of corticosteroid. The Hench observed that pregnancy and jaundice reduces the risk of rheumatoid arthritis. They reduces the pain, and at the same time he found that the corticosteroid level in their blood is high. So this, he concluded that corticosteroid can be used or glucocorticoid can be used in patients with rheumatoid arthritis or rather arthritis. So he got Nobel Prize at that time for this discovery. Allopurinol also invented in this period. Now, again a milestone in 1968, our own Dr. Anand A. Malavia, the living legend of Indian rheumatology, and his colleagues discovered methotrexate and its use in dermatomyositis. Until then, methotrexate is probably one of the most important drugs in rheumatology. It was approved by US FDA in 1988 to be given in the treatment of rheumatoid arthritis. We know the drug, we know the doses. Again, it can be a variety of doses from 2.5 mg orally to 50 mg subcutaneous per week. I am not talking about rheumatological dose. I am not talking about the dose in ALL, where we used to use intrathecal methotrexate 300 mg. I am only concentrating on the rheumatology doses. Now aspirin, another magic drug and probably the best and most active and effective drug in acute rheumatic fever. It discovered in 1970. Aspirin blocked the synthesis of prostaglandin, we know, and followed by so many numbers of NSAIDs in this path. If there is ibuprofen, there is paroxicam, meloxicam, ketodolac, so on and so forth. The different derivatives are there. Now comes the anti-malarial hydroxychloroquine. In 1951, chloroquine was used by Bagnall. We know the dose is between 200 to 600 mg. It can be given once daily dose, it can be given twice daily dose, and it's very important to mention here that this drug is one of the most used drugs among this COVID scenario as a prophylaxis. But when it is experimented, it is given in intravenous route, but we usually use oral route. And the dose was 800 mg twice daily, which is supratherapeutic as compared to our rheumatology dose. Sulfasalazine, initially used so rampantly, so frequently, nowadays a bit back foot after coming of newer drugs. It is used in rheumatoid arthritis, ulcerative colitis, Crohn's disease. It can cause many problems as well, bone marrow suppression, Steven Johnson, etc. Its proposed mechanism of action is inhibition of prostaglandins again. Its anti-inflammatory effects is in colon first, then active metabolites comes in liver as 5-aminosalicylic acid. Leflunomide. Leflunomide is invented or discovered in 1998. It's a pyrimidine synthesis inhibitor, dihydroorotate dehydrogenase inhibitor. It's given usually 10 to 20 mg oral dosing. Initially, the loading doses was given, but presently it's not recommended. And in older people, loading dose is not at all recommended. Now comes the most modern era, that is 2001 to 2022. The era of MAPS and NIPS, monoclonal antibodies and oral biologics. Though this particular drug is invented in 1998, as it is a biologics, I keep it in 2000 because hardly we can use before 2000 in Indian scenario. Etanercept is a TNF alpha antagonist or tumor necrosis factor inhibitor. When we go to the molecular level of rheumatology, we come and get our understanding that the selective inflammatory mediators are very much important. And if we can block those inflammatory mediators in a selective way, we can prevent the complications, less side effects. At the same time, the drugs will become more and more efficacious and also for a long period of time. We know that TNF alpha is a pro-inflammatory cytokine. Similarly, interleukin IL-6, IL-1, IL-17, IL-23. These are the molecules which are selectively, if inhibited, can give a significant relief in rheumatological symptoms in terms of joint synovitis, in terms of the systemic manifestations of rheumatological disorders. So, these MAPS and NIPS are now coming one by one. Etanercept, infliximab, and adalimumab. These are the three drugs. Out of them, infliximab is injectable or has to be given IV. All these three are injectable, but this one has to be given IV, intravenous. And etanercept and adalimumab can be given, they are subcutaneous. Adalimumab every 15 days distribution and etanercept every 7 days if it is 50 mg or twice weekly if it is 25 mg. Similarly, TNF alpha is there, satralizumab, golimumab. These are all invented in 2009. One is 400 mg subcut, another is 50 mg intravenous. It is given in rheumatoid arthritis along with psoriatic, Crohn's disease, Angst-Bond, and non-radiographic axial spondylopathy. Now comes the NIPS. Tofacitinib is a selective JAK inhibitor, that is Janus kinase inhibitor. 5 mg twice daily dosing. It's used in rheumatoid arthritis, psoriatic arthritis, and ulcerative colitis. It's as a co-partner of methotrexate, and sometimes when the person is intolerant to methotrexate, it is used more. Its inhibitor of Janus kinase is 1 and 3. Similarly, the two other, baricitinib and upadacitinib, these all came, one is 2018, one is 2019. You can see baricitinib is again JAK1, JAK2 inhibitor, doses are 1 to 4 mg. And upadacitinib is only approved in 2 years back, 15 mg dosing. If we see the interleukin 6 is another anti-inflammation, and I already told that interleukin 6 is a pro-inflammatory cytokines, sarilumab and tocilizumab. Tocilizumab is rampantly used this COVID scenario, and IL-6 was a marker of COVID severity in our critical care setup in COVID-19 severe patients. Rituximab is very important and versatile mAb, which is used in non-Hodgkin's as well as chronic leukemia previously. Now it is using in rheumatoid SLE and all are serious diseases of rheumatology where normally drug therapy fails. Selective T-cell co-stimulator modulator, abatacept. It's invented in 2005. It's used in moderate to severe active RA. Only issue there is that it has intravenous infusion, 50 and 87.5 mg. Similarly, IL-1 receptor is anakinra. It is invented in 2001. It's given in 100 mg subcut or 1 to 2 mg per kg per day. It needs a daily dosing. IL-17 inhibitor, secukinumab and iskikinumab. IL-17 inhibitor is also a inflammatory cytokine. IL-17, it blocks these two. Similarly, IL-23 inhibitor is guselkumab and risankizumab. These two are interleukin 23 inhibitors. So these are the different MAPs along with ustekinumab in psoriasis and psoriatic arthritis. So these MAPs and NIPs, they come into play in a selective way of inhibiting interleukin 6, interleukin 1, interleukin 17 and interleukin 23. And it's very much effective in use of TNF alpha antagonist failure. When we are seeing the failure of adalimumab or etanercept in patients, those cases, these are very much effective. And the two oral drugs found in psoriasis and psoriatic arthropathy, apremilast, is initially given 10 mg dosing once or twice and then is gradually built up to 30 mg twice daily. Is a phosphodiesterase 4 inhibitor, is also come in the armamentarium in after 2010. Similarly, iguratimod is again an oral drug, 25 mg, anti-inflammatory and used together with methotrexate in Japan and China. Now, after drug, it comes the diet. What are the diets? Hippocrates initially thought that there is a barley bread and barley water is useful in gout. Similarly, purine-rich food increases hyperuricemia seen by Garrod. So Hippocrates also advised purgative therapy for the treatment of gout. Now, if we see the modern views, omega-3 fatty acids, polyunsaturated and monounsaturated, along with iron-rich foods, particularly lean red meat, eggs, green leafy vegetables, good sources of calciums like low-fat milk, yogurt, cheese, high vitamin D-rich products, high-dose fish oil. These can cause symptoms reduction in rheumatoid arthritis, particularly morning stiffness, number of swollen and tender joints and joint pain. Exercise, stretching, walking, flowing movements, pilates, water exercises like body water. This can increase flexibility, range of motion, cycling, strength training, hand exercises and gardening. Similarly, physiotherapy, both in hot cold application, electrical stimulation along with rehabilitation mechanism, along with occupational therapy and relaxation exercises like rhythmic breathing, deep breathing, visualizing breathing, progressive muscle relaxation, relax to muscle music and mental imaginary relaxation. These are all components or armaments of rheumatological diseases in elderlies, because elderlies are better responded with these therapies along with drugs. And in case of some selective cases like arthroplasty, resection arthroplasty, arthrodesis, synovectomy, release repair, resection nodules, these are some selective surgical operations like including hip and knee replacement surgeries that helps in rheumatology treatment. Now, summarizing my case, the medical science therefore is truly battlefield. It needs armaments. Rheumatology being a part of medical science is always in a state of war. The war is now still there with COVID, and the old rheumatology treatment and therapy and complications all are our enemies, and we need to kill them or reduce them or control them. The war is within. Both enemies and army are inside in rheumatology. This is the difficult part of our subject. Gold compounds, penicillamines are now obsolete. NSAID, selective COX-2 inhibitor, non-selective COX inhibitor, corticosteroids, DMRDs. These are all time-tested medications. And the new era of monoclonal antibodies and oral JAK inhibitors, newer and promising, but as yet to be tested. So like where the approach should be from all possible directions, like diet, exercise, physiotherapy, occupational therapy, surgery, and in resistance cases, surgery. So if we consider a person and a rheumatological disease and his age, we have to be coordinated in terms of its exercise, medication, drug therapy, and along with environment. This gold and penicillamine, these are older things. Now these are the time-tested weapons or armaments, and now these are the advances. And with this, we have to do a multi-modality approach like this, as we are doing all the possible areas, air, water, and land. Similarly, medications, drug therapy, yoga therapy, all should be going together. Even after this, you can see these things. The nature and the environment changes along with this type of environments. The same person, same ladies, they are changing their moods and their environments with their outside. So we have to change. The aged patients, aged persons should have to be adapted with the difficult environment. And if they can adapt in this way, they can even lead a very good and healthy life as they are doing here with all the precautions, safety, and the measures of medical as well as non-medical equipments. We can give the patient a musculoskeletally healthy life and that can enjoy aging. Thank you for your listening.
It was a very informative and a comprehensive talk related to the armaments in rheumatological management. I would like to, right from the historical aspects to the pharmacological, non-pharmacological, as well as the surgical line. So addressing all the determinants is what Sir has spoken up in today's session. So if related to the questions in the chat box, there are no questions here. If anybody from the online or from the offline session would want to ask a question, or anybody who is online now could want to ask the questions, the session is open for discussion. We would take a maximum of 2 questions because of lack of time.
My question to Dr. Chatterjee is, what is the initial duration of JAK inhibitor? Like, as you mentioned, what is the duration in the elderly population after starting, after initiating?
You mean to say how many days we can continue?
Yeah.
That at
with
this moment,
monotherapy or along with methotrexate, or
the classical problem and classical solution in these 2 ways, we can start with methotrexate in these patients. If the patient is already on methotrexate, if he is controlled, then we can continue with methotrexate. If we are getting any side effects of methotrexate, at the same time, if the disease is not controlled adequately in terms of symptoms and DAT scoring, we can add in these patients tofacitinib, because baricitinib and upadacitinib is not yet available freely in the market. So we can begin with 5 mg once daily. There is some side effects of this particular drug, and both of these 2 drugs can causes increased prevalence of tuberculosis, can causes bone marrow suppression, liver problems, etc. So we can monitor the patient very closely, maybe 15 days interval, and after the patient gets settled with these 2, most of the time they get settled, we can increase it to twice daily. We can increase methotrexate up to 15 mg as well. Preferably we should avoid giving methotrexate in elderly people more than 20 mg. So it's better to go maximum up to 15 mg methotrexate, followed by 5 mg once daily, and if tolerated, 5 mg twice daily can be given. And maximum data available for tofacitinib is up to 5 years. We can give 5 years safely, but those data are not among the older people. The data is in the younger people. So we have to be very much cautious. Along with that, we have to give a periodic monitoring in these patients.
One question, Dr. Chatterjee.
Please.
We know that tocilizumab is associated with weight gain. Methotrexate is not. So, in your personal experience, in those patients who are obese with rheumatoid, so what is your personal experience of using tocilizumab in these patients? Because there is a possibility of further weight gain.
Yeah, definitely. If we found that the patient having the other choices, like if the patient can well tolerate TNF alpha antagonist, we can give TNF alpha antagonist to them. If they are not, if they are resistant to TNF alpha antagonist, we have to give tocilizumab in those patients. We have to be very much cautious as we are giving insulin in obese patients, knowing that the insulin also causing weight gain. We have to counsel them, they should have adequate exercise or other, if possible from our side. If we have quite significant armaments in our hand, we can give other biologics to the patients as well. So we can give secukinumab if the patient is an angst patient. So if possible, we can give others, and if not possible, we will counsel, we will ask them to go and good exercise and all those things to keep their weight normal.
Thank you.
Thank you, sir, for highlighting the important aspects. Due to lack of time, we would like to. So it was an excellent session, and thank you very much, Dr. Chatterjee, for highlighting the important aspects.
Thank you. Thank you.
Thank you.